The simplified approach to battlefield analgesia has two primary goals. 1. To reduce pain to a tolerable level while still protecting the casualty's airway and mentation. And 2. To allow casualties to return to the fight when possible.
Analgesia on the battlefield should generally be achieved using one of three options depending on the level of the casualty's pain and the nature of his or her injuries. Option 1. For mild to moderate pain, and if the casualty is still able to fight,
give 2 500 mg tablets of acetaminophen every 8 hours
and 15 mg of meloxicam once a day.
Option number 2. For mild to moderate pain, if the casualty is not in shock or respiratory distress,
and the casualty is not a significant risk of developing either condition, give oral transmucosal fentanyl citrate 800 micrograms. Place the lozenge between the cheek and the gum, but do not chew the lozenge. Option 3. For moderate to severe pain and the casualty is in hemorrhagic shock or respiratory distress or is at significant risk of developing either condition,
give ketamine 50 to 100 mg IM or IN or ketamine 20 to 30 mg slow IV or IO push. Repeat dose Q 20 to 30 minutes PRN for IM or IN.
Or Q 20 minutes for IV or IO. Stop when either pain is controlled or the development of nystagmus, rhythmic back and forth movement of the eyes. Ketamine has a very favorable safety profile. Few, if any, deaths attributed to ketamine as a single agent.
It is safe to give ketamine to a casualty who has previously received fentanyl.
Remember,
casualties should be disarmed after being given fentanyl, ketamine, or midazolam.
Document a mental status exam using the AVPU method prior to administering opioids or ketamine.
For all casualties given opioids, ketamine, or benzodiazepines, monitor airway, breathing, and circulation closely.
The fentanyl lozenge saves time because it does not require IV or IO access. It is very fast-acting and works almost as fast as IV morphine. Remember, do not chew the fentanyl lozenge. Let it dissolve. As an added safety measure, we recommend taping the lozenge on a stick to the casualty's finger or utilizing a safety pin and rubber band to attach the lozenge under tension to the casualty's uniform or plate carrier.
Reassess after 15 minutes and add a second lozenge in the other cheek as necessary to control mild to moderate pain.
Continuously monitor for respiratory depression.
Naloxone 0.4 mg IV, IM, IO, or IN should be available when using opioid analgesics. Traumatic brain injury and/or eye injury does not preclude the use of ketamine. However, use caution with oral or IV fentanyl, ketamine, or midazolam in TBI patients, as this may make it difficult to perform a neurologic exam or determine if the casualty is decompensating.
Ondansetron 4 mg can be given every 8 hours as needed for nausea or vomiting.
It can be given as a 4 mg oral disintegrating tablet that quickly dissolves and is swallowed with saliva. It can also be given as a 4 mg slow IV IO push or as an IM injection.
Each 8-hour dose can be repeated once at 15 minutes if nausea and vomiting are not improved. Do not give more than 8 mg in any 8-hour interval. Oral ondansetron is not an acceptable alternative to the oral disintegrating tablet formulation.
Promethazine is not recommended by COTC.
Aspirin, Motrin, Toradol, and other non-steroidal anti-inflammatory medicines, other than Mobic, should be avoided while in a combat zone because they interfere with blood clotting. Aspirin, Motrin, and similar drugs inhibit platelet function for approximately 7 to 10 days after the last dose. You definitely want to have your platelets working normally if you get shot. Anybody who might be going into combat in a week or less should never get aspirin, Motrin, or similar drugs. Mobic and Tylenol do not interfere with platelet function. This is the primary feature that makes them the non-narcotic pain medications of choice. The contraindications for fentanyl are hypovolemic shock, respiratory distress, unconsciousness, and severe head injury. Do not give fentanyl to casualties with these contraindications. You can kill your casualty if you forget these points. Ketamine can safely be given after a fentanyl lozenge.
The routine use of benzodiazepines, such as midazolam, is not recommended for analgesia. Benzodiazepines should not be used prophylactically and are not commonly needed when the correct pain or sedation dose of ketamine is used. Polypharmacy is not recommended. Benzodiazepines should not be used in conjunction with opioid analgesia. When performing procedural sedation, benzodiazepines may be considered to treat behavioral disturbances or unpleasant emergence reactions. But if a casualty appears to be partially dissociated, it is safer to administer more ketamine than to use a benzodiazepine.
In summary, use the simplified triple option approach to battlefield analgesia. Remember the contraindications and dangers with each option and combination. The goal is effective pain control without causing harm.